be with you today. Firstly, I'd like to thank you for events organization team. Secondly, I would like to thank you for the invitation to share my research with you. Even though cardiovascular disease remains a leading cause of death in the world, with more than 70.5 million deaths every year, and these are likely to increase by more than 20 million in the next decade. The same occurs in Brazil, since cardiovascular disease has been the leading cause of mortality since the 1960s, responsible for a substantial burden of such disease. Cardiac surgery is one of the most complex fields of medicine. It's a demanding specialty that involves high-risk procedures in various phases of care, which mobilizes the multidisciplinary team to improve this specialty. Thus, high workload associated with a multitasking profile creates an environment conducive to surgical heroes, which requires the use of means and instruments that favor the prevention and boost patient safety. So, the use of a checklist is a strategy aimed to promote to improvement of care of surgical patients as it reduces complications, adverse events, and is also low cost, being accessible for different realities, even where resources are limited. It's an instrument for quick and objective checks, which they are recommended to be used by all professionals in the surgical team, as it enables safer care processes. The checklist is a flexible tool that can be formatted according to the complexity of the procedure. WHO encourages adjustment, simplicity, applicability, and maturity. So the proposal was to develop a checklist that incorporates the recommends by the WHO. While the impact of a safety checklist is clear, the essential itinerary benefit is that it provides a specific tool to engage a team and ensure minimal standards are met, avoiding ambiguity and encouraging participation by all team members. The identification of causes and the elaboration of plans, combined with the use of more specific checklists, can minimize or eliminate the risks of the development of adverse events, allowing the establishment of a system that guarantees patient safety. Although the instruments currently used include general risk factors, they often do not cover the specifics necessary for proper management in cardiac surgeries, because several specific research are used, such as cardiopulmonary bypass, machining to bypass the heart, use of defibrillation to monitor intrathoracic impedance, temperature control to induce hypothermia, and the use of a solution for myocardial protection, among others. This is a methodological research for checklist validation carried out in the following stages: integrative literature review, constructions of items, and content validations by regional and national experts. Thus, the recommendation of the theoretical procedures were followed with the used criteria of clarity, relevance, and content validation to represent the dimension of the subject addressed. To start stage 1 integrative review, the research question was elaborated based to P goal strategy, with P corresponding to patient safety, I to the checklist, and CO to safe cardiac surgery, with the object of identifying in the literature which checklists are available to safe cardiac surgery. The process of selection the articles was independently carried out between July and November 2020 by two researchers. To organize it, the event found Equator flowchart and the preferred reporting items for systematic review and meta-analysis checklists were used. For stage 2 constructions of the instrument, the items extracted from the integrative review articles, the WHO Safe Surgery Checklist and the author's experience were used. The structural model of the instrument was designed to maintain and objective to easy to apply structure in which each item was composed of Nakamoto's responses aimed at solving the item. After creating the checklist, stage 3 began. For composing the sample of judge experts of stage 3 and 4, the criteria indicate the number from 60 to 20 were met, with emphasis on the number being odd on the order to avoid the possible ties. The inclusion criteria for stage 3 involve professionals who work in the surgical anesthetic scenario of the categories anesthesiologist, surgeon, or nurse, and in more than one health service, with a specialty registered with their respective professional council. A recruitment was performed using the snowball technique. The first version of the instrument was sent to 13 professionals in print format or sent via email to assess two criteria for clarity and relevance, with 3 anesthesiologists, 4 nurses, and 6 cardiac surgeons. In stage 4, content validation was carried out with professionals from all over in Brazil, which was necessary because it involved the expertise of specialty at the national level, not being restricted to evaluation at the regional level. Thus, research was carried out on the LATS platform, and 50 judges were eligible, including nurses, surgeons, professionals, experts in the field of the instruments validation, anesthesiology, and perfusionists. As for the result of the content validation of version 1, it should be emphasized that all judges have expertise in cardiac surgery, participating directly in the Surgical Anesthetic Act. Most are men, 55.6%, aged between 20 and 40 years, 66.7%. Time applied science graduation, 10 and 20 years, 44.5%, with medical profession, 60.7% in the field of anesthesiology, and 33.3% were nurses. For inclusion, a minimum score of 5 points was established. The invitation to participation in the study was made by the email with the presentation of information about the research and the checklist version 2 to be evaluated based on the criteria of clarity, relevance, surgical stage, and the responding professional. Judges who reported the reason that prevented participation in the study and those who did not return to complete an instrument during the data collection period, 50 days after the invitation, were excluded from the sample. Finally, 14 judges evaluated the instruments within the estimative period. Uh, in the second validation stage, 57 of the judges received a maximum score of the 20 points according to the criteria. 64.3% were women, 35.7% were older 60 years old, 50% had graduated more than 30 years ago, and 42.9% were nurses. And 71.4% of the judges had a doctorate. For data analysis in the stage 3 and 4, the agreement rate method was adopted using the following formula. The results following stages: integrative literature review, constructions of items, content validation by region and national experts. This chart present evidence-based information. The following information was extracted from the 8 articles. Characterization of the study include the author, country, and year of the publication, surgical of the use of the instrument professions involved, instruments format, and item corresponding to each safety check, tabulated in Excel spreadsheet. This part is the continuation of the characterization of the articles. In the first version of the checklist built for cardiac surgery, consisting of 3 surgical moments, 49 items were constructed with an indicator of the respondent and the dichotomous answers guided the answers for each item. At the signing phase, before the cell inductions, 98 items were created. In the time-out phase, before skin incision, items 20 to 42 were created, and in the sign-out phase, before the patient leaves the operation room, 7 items were created, 43 to 49. The changes between version 1 and 2 were adjusted to clarify the contents, resulting 3 questions excluded, 5 written, 11 repositioned, and the professional category responded, and 6 written repositioned. These resulted in version 2 of the checklist with 46 items. After adjustments were made to the 3 phases of the checklist, version 2 was submitted to the judge at the national level for the second stage of the content validation. This is an instrument version 2 items with a percentage of about 18% were validated, and those with a low percentage were discussed, rewritten, eliminated, or readjusted as suggested by the experts. Were chose to present this category as a presentation because it had a great perception of validation. In this list of items, 19 were written, 12 were maintained, 7 were excluded, 3 were repositioned, and 5 were written and repositioned in the professional category to respondents. Validation of the self-surgery checklist of the study sought to address the specific needs of cardiac surgery during each of the stages. We attempted to include the evidence from the literature, the suggestion of experts, and the experience of the authors to obtain a tool that helps the nursing team and the medical surgical team to ensure that the procedure is safe. proceeding the checklist with key safety posts and facilitating its use in daily life in line with the purpose. The development of this study made it possible to validation checklists for safety cardiac surgery in a three-phase format. Identified by Rome, the verification item should be referred. It is a tool that can be used by the surgical team for safe care for patients undergoing cardiac procedures. The checklist for safe cardiac surgery with a question addressed to the response professional consists of 41 items and proved to be a valid instrument. It's a promising tool capable of mitigating the occurrence of adverse events if implemented and used properly. Finally, the validation checklist should also be compared with other cardiac surgery checklists for ease of use, exertion time, and staff address, as well as for its performance and outcome indication related to adverse events in cardiac surgery. Thank you guys, and I'm very happy to share my research with you today. Thank you very much. Here are the reference, and I'm available for the questions. Thank you very much again.
Thank you so much, Dr. Alpha Thome. Since she is not available, she just shared her presentation.